Hello. Okay, it's 11 o'clock Pacific time, so we'll go ahead and get started. Welcome to the Connect virtual conference. We're so excited to be launching this event and bringing you some incredible speakers over the next 5 weeks or so. My name is Lacey Bergevin, and I'll be your host today. So first off, welcome and thank you for joining us. I hope you can hear me okay, but if you're having any audio issues, please let us know in the Q&A box on the right-hand side of your screen. Before we kick off our session, I'd like to take care of a few housekeeping items first. We're scheduled for 60 minutes of content with Q&A today. If you have to leave the session early, we'll be posting recordings daily in the Facebook group. More info to come at the end of the presentation on how to join that group. And we'll be sending an email at the end of each week with all the recordings from that week. We encourage your participation throughout the session, so please don't be shy. The Q&A box will remain on your screen throughout the entirety of the presentation. Please type questions in at any time. Also, if you're having technical difficulties during the session, you can seek help in the Q&A box as well. We have a team that's ready to assist. Our goal is to offer CE credits for all courses. The evaluation and quiz will be sent with recordings at the end of the week. Your CE certificates will be issued within 60 days. Okay, with that out of the way, it is my pleasure to introduce our presenter for today, Kathryn Gilliam. Hygienist Kathryn Gilliam is a proponent of incorporating the latest scientific research on the multiple oral systemic leaks into practical clinical protocols. Kathryn is a national speaker and a key opinion leader for multiple respected dental companies, including Carefree. She has published multiple articles and continuing education courses in leading dental journals and serves as a faculty member and dental hygiene specialty coach for the Productive Dental Academy. Kathryn's interest in the medical side of dentistry led her to years of advanced study in the oral systemic links, including graduating with an advanced arterial wellness certification from the prestigious Bale-Donine preceptorship for CBD prevention. She also earned a fellowship with the American Academy for Oral Systemic Health in 2018. After 30 years as a hygienist, she still loves her career and feels her purpose is to love her patients back to health. On a more personal note, I have had the pleasure of hearing Kathryn lecture in person several times, and she's so passionate about what she's teaching that she has actually moved me to tears before. We also have Dr. Kim Cooch joining the conversation. He's the founder of Carefree, and Dr. Cooch also has an impressive resume, and we're lucky to have him as our resident caries risk management expert. He's newly retired from private practice after 40-plus years, but he's managed to remain as busy as ever with giving back to his dental community and speaking engagements. Dr. Cooch also continues publishing papers in journals. He acts as a scientific advisor on dental caries for the prestigious Coy Center in Seattle, and he's a scientific reviewer for multiple journals. The bio I've just read only begin to scratch the surface of what these two have done for their respective communities. Dr. Cooch, would you like to say a few words to officially introduce Kathryn?
Yes, I would, and I'd like to welcome everybody to our second lecture in the series of this Connect virtual dental meeting, which I'm really excited about. And I met Kathryn quite a few years ago and have invited her to speak at several different dental meetings and have crossed paths with her, at dental meetings. And I just have to tell you, I'm so excited, Kathryn, to have you here today. You are one of the most respected, in my opinion, hygienists and professionals, and your dedication and the person that you are, I'm proud to call you my friend. So I'm excited to hear you today. So everybody is in for a treat. So Kathryn, take it away.
Thank you so much, Lacey and Dr. Cooch. I'm incredibly honored to be invited to speak here today, and those introductions were very, very sweet and mean so much to me. I do love being a dental hygienist. I've loved it for over 30 years. But my career as a whole health dental hygienist began about 20 years ago, the day that I learned that my best friend, the healthiest person I've ever known, had passed away. I met Steve the first day of our senior year of high school. He caught my eye and said, "Hey, if you don't have anything nice to say, come sit next to me." So I did, and we were best friends ever since. Steve had a wicked sense of humor, and he was the most loyal and protective friend. In fact, when we were in college, my boyfriend had to get Steve's approval before we could get engaged. Steve was also a great role model of fitness and health. He worked out, he ate well, he had regular medical and dental checkups, and at his last physical, Steve passed the stress test and got a clean bill of health. But the very next day, playing basketball with his youngest son, Steve had a massive heart attack, and he died. He did not have high blood pressure. He did not have high cholesterol. Steve had periodontal disease. And I can't stop wondering, what if Steve had had a dental hygienist who told him about the connection between a little bleeding and the increased risk of a heart attack? I know he would have done whatever he could to improve the health of his gums had he only known. He just didn't know. I'd give anything to bring my friend back. But sadly, I can't change Steve's story. But what happened to Steve changed my story. I realized that dental hygienists are no longer teeth cleaners. It's time to elevate our identities. Dental hygienists are frontline healthcare practitioners, and we have a tremendous responsibility. But more than that, we have a tremendous opportunity. We have the opportunity to make a difference in the health and longevity of our patients by sharing what we know about the connection between oral health and whole body health. This is what fuels my passion for patient care and for sharing this information with my coaching clients and conference attendees. And in my presentation today, I'll share just a few tips to transition a practice from traditional dental care to life-saving whole health care. And you will save lives and families and friends, maybe even your own. Just imagine if you identified your pregnant patient's gingival inflammation and your treatment prevented a preterm low-weight birth or even a stillbirth. It could be the difference between a devastating heartbreak or a joyous celebration. How would that feel? And imagine if you diagnosed periodontal disease in a patient who otherwise appears to be perfectly healthy, like Steve. And imagine, unlike the dental hygienist who treated Steve, you were proactive and you eliminated the inflammation and reduced your patient's risk of cardiovascular disease. And your patient lived. He lived to see his children graduate from college and get married and have children of their own. How would that feel? This is the opportunity dental hygienists have to save lives. And this is the opportunity we've been waiting for, to step into our new identities as life-saving healthcare practitioners. My friend Steve just didn't know, but we do. We know that on a good day, we save a smile, and on a great day, we save a life. So this is what started my journey into discovering more about the connections between oral disease and systemic diseases. And today I'm going to cover the basic science of the oral systemic links. In the coming days, you'll hear from Dr. Doug Thompson, Dr. Susan Maples, and other experts in this field who will connect oral disease and multiple other diseases. So today we'll start with the foundational science of the links between oral disease and systemic diseases. And my hope for you is that you'll lift the science off the page and put it into action in your practice. Again, I'd like to say thank you to the team at Carefree and especially Dr. Kim Cooch for inviting me to speak to you today. I'm incredibly honored to be here and to have this opportunity to share my passion for saving lives in the dental office. As a national speaker, I am a representative of various companies, and I'm not receiving any compensation to speak to you today. I would pay to be able to do this. Our objectives today are that you will comprehend the role of Keystone bacteria and the effect of inflammation on systemic health, and that you will understand the significance and challenges of oral biofilm, and that you'll discover how medical wound care protocols can be utilized to enhance the treatment of periodontal disease. And my personal objective is to move the needle when it comes to clinicians taking the science that is now well established and begin to actually change clinical protocols and make a real difference in patients' health and in their lives. Now, as I said, I love being a dental hygienist. I always have. And when I graduated from dental hygiene school, it seems like over 100 years ago, the focus was on creating glassy, smooth root surfaces. Now we know the goal is to disrupt the bacterial biofilm and create a healthy and stable microbiome. The focus has shifted to more whole body care. Now back then, my goal was for every patient to say that I was the most gentle and the most thorough hygienist they'd ever had. And that remains one of my goals to this day. But now my goals also include wanting to hear, "Thank you for finding my husband's high blood pressure," or "I no longer need my diabetes medication because my gums are finally healthy." That kind of thing rekindles the spark I feel every day when I take care of my patients. And I want you to feel that spark too when your patients are healthier and they appreciate your role in helping to make that happen. And this is actually the first graduating class of dental hygienists from the Phone School of Dental Hygiene at the University of Bridgeport, Connecticut in 1914. That was actually a couple of years before my time. And speaking of 100 years ago, Dr. William D. Miller was a scientific pioneer in dentistry and the first oral microbiologist. And he knew in 1880 that oral bacteria are the cause of most of the illnesses that we face. Now, over 140 years later, the rest of us are finally getting that message. And some of the most highly regarded physicians have gotten that message as well. Dentistry is a medical specialty. We're trained in the diagnosis and treatment of a specific part of the body. The mouth is our specialty. And newsflash, it's connected to the rest of the body. Now it's time for a shift in our thinking. Periodontal disease is now considered a complex oral and systemic disease. So oral is systemic. Now this is Dr. Bradley Bale, who spoke at this conference yesterday, and one of my heroes like Dr. Cooch. Dr. Bale is the co-author of Beat the Heart Attack Gene and co-founder of the Bale-Domin method of cardiovascular disease prevention. And he and his partner and co-author, Dr. Amy Donin, who will also be presenting a program for this Carry-Free Connect series, they give a 17-credit-hour intensive 2-day course for healthcare practitioners called the Bale-Donin Preceptorship. I took that course in 2014 and 2017, and it's one of the most informational, transformational, eye-opening courses I've ever attended. And I'm a CE junkie. I highly recommend that course, that Bale-Donin Preceptorship, for every clinician in this audience. And it was at that course that Dr. Bale said, periodontal disease is a medical disease with a dental solution. We need to shift our thinking and realize that periodontal disease is a medical disease that just happens to be in the mouth. And this is Dr. Bale's partner and his physician, Dr. Amy Donin. And both Dr. Bale and Dr. Donin said that they cannot keep their patients cardiovascularly healthy and stable without a dental hygienist keeping the patient periodontally healthy and stable. This is our time, ladies and gentlemen. It's our time to step into our identities as healthcare practitioners. And in this article for RDH magazine, Dr. Donin wrote, registered dental hygienists have the knowledge, skill, and professional education linking oral health and vascular health. Oral health has a direct impact on the vascular system, with periodontal and endodontic disease directly associated with vascular disease development, heart attack, and ischemic stroke risk. The complexity of vascular disease, atherosclerosis, requires an inclusive approach to care, including the oral health care specialist. That's who we are. We are oral health care specialists, and we need to step up and into this identity. We're responsible to address the oral and the systemic health of our patients. So what is the oral systemic link? There are actually multiple links between oral diseases and systemic diseases, but for clarity, we'll answer this question as it is for now. The oral systemic link refers to the connection between oral disease and whole body diseases. So how does that happen? It starts with oral bacterial pathogens that create inflammation in the mouth and in the body. The chronic inflammation that's caused leads to a variety of diseases, as we'll see in just a few minutes. Now let's review inflammation. Acute inflammation is our immune system response to injury and invaders. Infection or injury trigger a chain of events called the inflammatory cascade. So inflammation begins when pro-inflammatory hormones call out for your white blood cells to come and clear out infection and damaged tissue. So we see heat and pain and redness and swelling at the site of the injury. And then the anti-inflammatory compounds move in once the threat is neutralized, and they begin to clean that out and begin the healing process. So acute inflammation that ebbs and flows like that is needed. It signifies a well-balanced immune system. But symptoms of inflammation that don't recede are telling you that the on switch to your immune system is stuck. It's poised on high alert, even when you're not in imminent danger. So in some cases, what started as a healthy mechanism, like building scar tissue or swelling, just won't shut off. And the result is chronic inflammation. Our bodies are literally on fire inside. Most of us, hear me now, most of us are walking around on simmer with chronic low-grade inflammation that sets us up for multiple different diseases later in life. Now we know that bacteria and inflammation lead to oral disease and systemic diseases. So let's look more closely at oral diseases. First, we'll look at the prevalence and incidence of periodontal diseases. A 2010 study in the American Journal of Dentistry looked at the population of adults between the ages of 18 and 90 years old who had no attachment loss. And they found that 93.9%, almost 94% of them, have gingival inflammation, which we refer to as gingivitis. This represents an enormous opportunity with this patient population, people between 18 and 90 years of age, an enormous opportunity to recognize the level of inflammation and treat these patients before disease progresses to full-blown periodontitis, in which we see loss of attachment. We have the opportunity to help these patients return to health and possibly prevent serious systemic diseases. But be aware, even at this stage of incipient periodontal disease, at the stage of gingivitis, we can absolutely see systemic damage. We don't have to have attachment loss to have widespread systemic inflammation and resulting systemic inflammatory diseases. We can make a real impact on the health and the lives of our patients if we will intervene at the gingivitis stage and eliminate the inflammation in their mouths. Now, in this study by the CDC, published in the Journal of Dental Research in 2016, they looked at the national prevalence of periodontitis among adults aged 30 to 79 years of age. And we find that 45.2% have some form of periodontitis. This means theoretically that almost 1 of every 2 patients who walk in the door of your practice each and every day have some form of periodontal disease. This also represents a huge opportunity for us in making a difference in the overall health of our patients and a huge opportunity in growing our practices. These patients have likely been receiving prophylaxis procedures, which we'll see on the next few slides, which is obviously not the appropriate care for someone with periodontal disease. These statistics show us that our population has a staggering amount of periodontal disease, from incipient gingivitis to advanced periodontitis. So what we have is an enormous opportunity to offer better service to our patients and an enormous opportunity to grow our practices at the same time. Now, this study done by the Health Policy Institute looked at patients with private health insurance benefits to see which codes were used most often for 3 different age categories. Here we see for patients 19 to 34 years old, the code D1110, or prophylaxis procedure, was performed 72.3% of the time, and other codes, whether gingivitis therapy, which is D4346, or the non-surgical periodontal treatment with either code D4341 or D4342, those other codes were used only 27.7% of the time. Now remember, we just saw the prevalence of gingivitis and periodontitis are high, even in this age group. But here we see only 27.7% of patients are being treated with codes other than a prophy. Now, as we look at the next category, patients aged 35 to 49, we see they were treated with code D1110, the preventive procedure, 87.5% of the time, and the other codes were performed 12.5% of the time. Now, we know as people age, their risk for periodontal disease increases. And having just looked at the incidence and prevalence of periodontal disease, we can see there's a disparity here. Instead of seeing more of the gingivitis treatment code and periodontal treatment codes, as we would expect in this age group, we see fewer. In fact, only 12.7% of the codes were other than prophy codes, even fewer than for the younger age category. That just simply doesn't make sense to me. Now, as we look at the final category, patients in the 50 to 64-year-old age range, we see that there's an even greater disparity. We see the vast majority of those patients, 95.4%, are treated with the prophylaxis code, even though we know the incidence of periodontal disease is even higher in this age group. And not only is the risk of periodontal disease higher in this age group, but the risk of comorbidities of systemic diseases is much higher as well. Many also have cardiovascular disease or diabetes, for example. So this shows we are really dropping the ball when it comes to taking care of our patients. The ones who need it most are not being served appropriately. So what is happening? Why are we not treating our patients appropriately? I consult with dental teams across the country, and when I talk to the hygienists that I coach, I hear the following reasons. Dental hygienists don't want to rock the boat. We don't want to upset people, and we're afraid of rejection and that people will leave the practice if we tell them news that they don't want to hear. People come in believing that they're healthy, and they come in for a cleaning and expect to receive the procedure that their dental insurance covers, which is a prophylaxis. So they believe that they're healthy, and then we find that they're not healthy, and we're afraid to tell them. I've never heard of a physician who is afraid to tell a patient that they have a disease. It's their job. And ladies and gentlemen, it is our job too. And it's our opportunity. It's our opportunity to help patients understand that they're not healthy, that they have some level of chronic inflammatory disease, and that this disease puts them at risk for other systemic inflammatory illnesses, and that they need some sort of periodontal treatment to address this oral infection and inflammation and to reduce their risk for systemic illnesses. This has been our opportunity all along, but now, in this time of unprecedented uncertainty, I believe that more than ever before, our patients will be coming in with inflamed gums and other issues from the increased stress of this global pandemic, and they will need more treatment than ever. Now, how do we get our patients to understand that they have a disease that must be treated? In the past, when our patients presented with inflammation and bone loss, we would show our patients their periodontal chart, which they don't really understand, and we would show them their x-rays, which they don't know how to read, and we would show them intraoral photos and other visual aids. That helped. We would talk and explain, And all too often, they were not convinced. It's pretty hard to convince someone who has no pain that they need to spend a lot of time and a lot of out-of-pocket money to treat a disease that they have no idea that they have. So their periodontal disease went unmanaged and their systemic health deteriorated. Now we practice a medical model of dentistry. Patients understand infections, they understand bacteria, and they understand lab tests. So when we show our patients their bacteria under the microscope and we show them their lab test results and explain those results and then relate those results to their individual risk factors, they understand the significance of that. And when they get it, they're motivated to act. And that makes our job so much easier. Now, unfortunately, this platform does not support video, so you'll have to take it from me, take my word for it, that this is actually a very active slide. And when we use technology like this, we can make a huge impact on our patients. It makes a big impression when they see multiple different bacteria squirming around on a slide, and they know that that bacteria was taken out of their mouths. This happens to be a very active slide. There are multiple long corkscrew bacteria that you can sort of see in the background. Those are spirochetes, a very large amount of spirochetes. There are also rods and cocci and white blood cells. So it's a very infected mouth that this slide was made from. I love salivary bacterial testing, another great technology that we have at our fingertips. And I found that telling patients a little bit of information that we get from doing this bacterial testing about a few of the bacteria in their particular mouth makes a big difference in the way they look at dental hygienists and dentists. Suddenly, they have a new respect for us as healthcare providers. We're no longer just the girl or the guy that cleans their teeth. Now they hear us saying things like, your saliva analysis has revealed an infection that includes the pathogenic bacteria, Fusobacterium nucleatum. And that really concerns me because we know that that particular bacterial pathogen has a very damaging effect on your cardiovascular system. It can make the blood vessel walls more permeable, allowing other pathogenic bacteria to enter the vessels, potentially leading to a blood clot that could cause you to have a heart attack or a stroke. Now, I can guarantee if you're not already using salivary DNA testing in your practice, your patients have never heard a dentist or a dental hygienist speak that way before. When we just say one or two specific facts about one or two specific bacteria that they can see on their lab report, let me tell you, that gets their attention. So today I'm going to give you a few facts that you can use to begin changing your identity in the eyes of your patients. We know also that we need intraprofessional communication and collaboration in order to create a wellness-based practice. We need to connect with medical doctors because we can't treat our patients' cardiovascular disease or diabetes or other systemic illnesses directly. Even though our care is vital to the successful elimination of that patient's inflammation, it takes a team of patients and dental professionals. We need a common language. So the link between medicine and dentistry, our common language, is data. Dr. Bale and Dr. Doneen require a bacterial DNA test, a comprehensive periodontal chart, a full series of x-rays, especially cone beam x-rays, for every patient that they see. Medical doctors look for the cause, for the bacteria or the virus or the other entity that causes the disease. They identify it, and they treat it with appropriate medication, and they cure the disease. Just like with strep throat, they do a culture, they get lab results, and then they prescribe the appropriate medication. That's the type of protocol that we can implement when we use bacterial DNA testing and when we use this medical model of care. But traditionally, that's not what we do in dentistry. We see a cavity, we clean it out, and we fill it. We don't address the strep mutans or the lactobacillus or the diet or the low pH or the dry mouth, whatever it was that caused that decay. We don't look for the root cause. We just repair the damage. And now that we collaborate with medical doctors to co-manage our patients, we must practice the medical model of dentistry. We must look for the root cause. When we shift to this medical model of dentistry, our work becomes so much easier. It's easier to communicate with our patients and with their healthcare providers. Now let's focus specifically on periodontal disease for a minute. This is the model of periodontal disease that I was taught in school. It's an inflammatory disease caused by specific pathogens that trigger an inflammatory response. Now, somehow, this model led us to believe that due to the time that it takes to build up sufficient numbers of periodontal pathogens to cause disease, we have time on our side to limit disease development. And I think that's why we would get into the habit of watching and waiting. And we got into the habit of telling patients, you have a little bleeding. We thought we had time to encourage patients to practice better hygiene, but now we know that is not the case. Even a little bit of bleeding signifies systemic inflammation and disease risk. One of the primary concepts central to this model of periodontal disease is that only periodontal pathogens cause periodontal disease, and the rest of the bacteria are either benign or beneficial. And research identified hundreds of oral bacteria, and they were classified as either red complex, orange complex, or green complex, etc., correlating to high risk, moderate risk, and low risk. So then we had a name for those specific bacteria in the biofilm. And there are 10,000 to 1 billion bacteria in one infected periodontal pocket. So we say that dental hygienists are in a continuous battle with bacterial biofilm. And as the biofilm continues to grow, some of its layers become anaerobic. And that bacterial biofilm harbors increasingly more dangerous, gram-negative, anaerobic, pathogenic bacteria. This is the microbiome that causes periodontal disease. The biofilm is covered in a protective slime layer, and it has adherence properties that keep it from being easily rinsed away, especially by over-the-counter mouth rinses. So make sure that your patients know that in general, over-the-counter mouth rinses don't work. I describe it like the slime layer on the rocks at the beach. No matter how many waves crash over the rocks, it's still slimy. That's the same bacterial biofilm that's on the teeth and on the roots of the teeth. Biofilms also have the capacity to calcify, which makes removal even more difficult. So keep this in mind. Biofilms are very different than if we have simple planktonic bacteria in the mouth. Those bacteria are easy to eliminate. A biofilm is much more difficult to control. So now, maybe 100 years after that original model of periodontal disease was developed, we now have this new model of periodontal disease, which was developed after research into the activity of the bacteria, how they act and interact with one another, and with the host. This goes well beyond identification of the bacteria. This new model is called polymicrobial synergy and dysbiosis. And this research fundamentally changes our understanding of periodontal disease. So what does that mean? Okay, let's break it down. Polymicrobial is pretty self-explanatory. It means we have a biofilm, a community of multiple different microbes. Synergy, when we're talking about business or on dental teams, means the increased effectiveness that results when two or more people work together. But in this definition, in the context of polymicrobial synergy and dysbiosis, it's actually much more sinister. Synergy refers to the concerted action of the community of those microbes, and that it's exponentially greater than it would be if the individual microbial species were working separately and not in a good way. So if you have individual planktonic bacteria in your system, it can cause an infection. But if you have a biofilm of different bacterial species all working together synergistically, the impact can be much more devastating to your health because the biofilm has these self-preservation properties, and it's much more difficult to eliminate than the planktonic bacteria. And again, a dysbiotic state is a state of imbalance and disease. So this theory is all about the increased virulence of the synergistic oral bacteria and how the damage they cause is multiplied when they work together. So how does it happen that the entire microbial community begins to work synergistically to create this state of imbalance and disease? Well, it happens because of the presence of certain keystone bacteria. The keystone pathogen hypothesis holds that certain low-abundance microbial pathogens can orchestrate inflammatory disease by remodeling a normally benign microbiota into a dysbiotic one. So it's been discovered that Porphyromonas gingivalis, or PG, a gram-negative anaerobe that colonizes subgingival tooth sites, elevates the virulence of the entire microbial community by interacting with and communicating with the other bacteria. That's known as quorum sensing. P. gingivalis changes the gene expression of other bacteria in the biofilm, allowing them to churn out toxic compounds that they don't normally produce. In addition to hijacking the genetic expression of the other bacteria, P. gingivalis impairs the host gingival immune response, and it's the immune response that keeps the bacteria under control. So by interfering with host immunity, PG enables the survival of all of the bacteria. And this is why PG is now considered a keystone pathogen. When I understood that a keystone pathogen in low levels can create these changes, my practice changed. I realized that we actually don't have the luxury of time before we see destruction. A low level of PG can elevate the virulence of the entire biofilm. So if I see any PG on my patient's pathogen results, I know that I need to treat with great urgency. This is why we should be treating patients at the first sign of gingival inflammation. We need to treat gingivitis and not watch and wait the disease progress to full-fledged periodontitis. That is end-stage disease. An endocrinologist doesn't wait to begin to treat a diabetic patient until their foot needs to be amputated. They treat as soon as the lab tests show elevated blood glucose. That's the medical model of care. That's our new model. We're in the prevention business. Let's prevent attachment loss. And while we're at it, we'll prevent other more serious conditions as well. Now, I'm a microbiology nerd, and I love my pathogens. And I know not everyone feels the need to know all the details of all 700 plus species of microorganisms that we find in the oral microflora. Fair enough. However, I believe it's important to become familiar with just a few of the most dangerous bacteria, so when you see them on a lab report, you can talk to your patients appropriately. You'll begin to recognize these bacteria the more lab testing that you do. These pathogens are implicated in many serious systemic conditions that affect our patients, and we need to recognize them and be able to connect back to them when we see them listed on the lab reports. There are other bacteria that you'll become more familiar with the more testing that you do, but for today, we'll just touch on what I consider to be the top few. Porphyromonas gingivalis. The most important things to remember about PG is that it's a keystone bacteria which increases the virulence of the entire biofilm community by changing the gene expression of normally benign and beneficial bacteria, so they all become pathogenic. Additionally, it impairs host immunity. And PG is pathogenic at very low levels. So because of these characteristics, when you see that PG is present in the biofilm, you know the condition is urgent. PG is found in atherosclerotic plaques and in ruptured intracranial aneurysms, so it's associated with cardiovascular disease, Alzheimer's disease, and many other systemic diseases. And PG actually increases the risk of a heart attack by 13 times, which is twice the risk of smoking. Tannerella forsythia. It's important to know that TF is commonly seen in advanced and refractory periodontal disease, and it's highly communicable. TF has been found in blood clots that cause heart attacks and strokes, and it's associated with diabetes and with adverse pregnancy outcomes. Treponema denticola, one of my favorites. The most important thing to know about TD is that it's a spirochete, and spirochetes are extremely difficult to eradicate. When an antibiotic or antimicrobial agent is introduced, spirochetes can go dormant. They transform into persister cells and will not be affected by medication. Once the medication leaves the body, the spirochete can once again be active. So spirochetal infections are often treated with a pulse-dose protocol of 2 or 3 different antibiotic or antimicrobial agents in a rotation in order to affect the cells as they become active again after being dormant. Treponema denticola is easily transmissible, and when you have spirochetes in the biofilm, you also have PG. They go together. So you know if you see those bacteria on your patient's lab test results, you know that is a very virulent biofilm, and you need to act quickly. Oral spirochetes are found in 90% of Alzheimer's cases, so there's a strong association. And Treponema denticola is also associated with cardiovascular disease, diabetes, and adverse pregnancy outcomes. Fusobacterium nucleatum. FN is an easily transmittable gram-negative anaerobe capable of systemic dissemination, causing infection at different body sites, and it's an enabler for other microorganisms to spread systemically as well. So that means that it opens the door for all of the other bacteria to enter the bloodstream by making the blood vessels more permeable. And it can cross the blood-brain barrier, and it can cross the placenta. FN has been proven to cause a full-term baby to die in utero. When I see FN on my patient's lab results, I know they're at risk for very serious systemic consequences. Now, AA is another serious pathogen, and what's most important to know about AA is that it's highly transmissible and it's difficult to eradicate, and it's associated with aggressive periodontitis. Now, just like the spirochete Treponema denticola, AA burrows into the tissues, and unlike other bacteria, it stays in the tissues even after full mouth extractions. So like the spirochetes, it's challenging to eradicate. Systemically, AA is associated with Alzheimer's disease, Parkinson's disease, cardiovascular disease, pancreatic and colon cancer, and many other systemic diseases. Streptococcus mutans. SM is a gram-positive bacteria that is extremely common and easily transmissible. We know that most of us have S. mutans. Strep mutans and lactobacillus and others cause tooth decay. In dentistry, we're very, very familiar with strep mutans. It's also a factor in cognitive impairment associated with cerebral microbleeds. It's linked to stroke and to dementia. Strep mutans are found in the thrombi, which are the blood clots in heart attack victims. So tooth decay has been listed as an independent risk factor for heart attack. Let that sink in for a minute. Tooth decay is a risk factor for heart attack and stroke. Now, fungi co-aggregate with bacteria in the biofilm. I point this out to make you aware that there are other pathogenic microorganisms present in the biofilm along with bacteria. And fungi are found in much greater abundance in people with periodontal disease than in those with healthy mouths. Fungi make the oral biofilm more virulent. And again, when you see fungi such as Candida albicans, you know you have a more virulent biofilm. So now when you see this, you think this. Our concern is more than just for eventual tooth loss. Now we're concerned about a heart attack or a stroke or multiple other systemic illnesses. So let's switch gears. Let's talk about the pathogens at work. We're very familiar with some of these pathogens, so how do they work in the body? There are 3 basic ways that oral disease is connected to systemic diseases, either by association, where we're at increased risk for systemic disease, but periodontal disease does not cause that disease, or by a causal relationship in where periodontal disease caused or initiated the disease, or by a bidirectional relationship in which periodontal disease contributes to the systemic condition and the systemic disease contributes to the periodontal disease. Now, there are multiple pathways of pathology. The first pathway that bacteria can be the source of infection is by inhalation. So the mouth can be so infected by the bacteria that it can be inhaled in the normal course of breathing. It can be in surgical intubation, or dental health professionals and patients can inhale bacteria in aerosol. The second pathway is that the bacteria have easy access to the bloodstream. Any dental procedure that can cause bleeding can cause a transient bacteremia. And even without dental procedures, the oral epithelium can be ulcerated, and the bacteria can gain access to the bloodstream through everyday activities such as chewing or toothbrushing. And the third pathway is through the initiation of the immune system response. This pathway is more complex to explain, but we know that acute inflammation is a beneficial process. It's how our body rids us of invading pathogens. So to simplify, let's just say the neutrophils rush in and kill and clean up the invaders, and then the fibroblasts move in to begin the repair process. But when the inflammation becomes chronic, the immune system is not able to complete this normal cycle of removing bacteria and restoring the body to health, and that's when we see tissue damage. One step triggers another, which is referred to as a cascade. And when we have keystone pathogens that can inhibit this immune response, we really don't have the same ability to control the bacteria. And this sets up the chronic inflammation that keeps our immune system stuck in the on position. Now, periodontal disease is a multifactorial disease with all of these different various components. I've read that genetics are responsible for 5% of periodontal disease, and we've already discussed the bacteria and how not only is there damage from pathogens, but if PG is the keystone bacteria that's present, the host immune response is impaired, and that leads to catabolism of bone and connective tissue. There are also other factors that affect the host immune response, such as diabetes, lifestyle factors like smoking, and diet. Now, it's through those pathways that periodontal disease creates chronic inflammation in the body, and the mouth is said to be the most abundant source of chronic inflammation, and periodontal disease is now connected to 57 different systemic diseases. We'll take a little bit of a closer look at a few of those diseases. Now, there's a bidirectional link between periodontal disease and diabetes, and people with diabetes have 3 times more periodontal disease than people without diabetes, and they have 3 times greater attachment loss and bone loss. And smokers with diabetes have 20 times increased risk of tooth loss than non-smoking diabetics. In 2013, in the Journal of Clinical Periodontology, it was recommended that all people with diabetes be screened regularly for periodontal disease. And I don't see this happening. Do your patients tell you that their physicians screen them for periodontal disease? Mine don't. So maybe we should be screening our periodontal patients for diabetes. And this is what's happening in some wellness practices. I believe Dr. Susan Maples will be talking about performing HbA1c screening in the dental office when she presents her program, I believe on Monday, April 20th. And when we look at periodontal disease and cardiovascular disease, that is a causal link. We know this because it's been proven in research that was published in 2016 by Bale, Doneen, and Vigorust. This landmark study showed that the keystone bacteria Porphyromonas gingivalis, or PG, is proven to cause atherosclerosis. People with oral inflammation are at 50% increased risk of heart attack and stroke. In fact, PG increases the risk of a heart attack 13.6 times, which is twice the risk of smoking. Non-surgical periodontal therapy has a significant beneficial effect on cardiovascular health, and that's why Dr. Bale and Dr. Doneen, who I mentioned at the beginning and multiple times, insist on working with a dental hygienist in order to co-manage their patient's inflammation. When oral inflammation is reduced, the risk for cardiovascular disease is reduced. Looking at the connection between periodontal disease and one of the most dreaded of all diseases, Alzheimer's disease, which is now the 5th largest cause of death in the world. This is an example of an association. We don't have proof that periodontal bacteria cause Alzheimer's, but we have strong evidence of an association. Alzheimer's is a complex, multifactorial disease, and oral bacteria may not be the primary cause. But there are 60 species of oral bacteria found in the blood, spinal fluid, and brains of Alzheimer's patients, and PG is found in more than 90% of Alzheimer's brains. Periodontal disease is linked to a 6 times increased rate of cognitive decline in people with Alzheimer's disease. And think about this. Baby boomers are now between 52 and 70 years old. When the first wave of baby boomers turns 85 in 2031, it's projected that there will be more than 3 million people aged 85 and over with Alzheimer's disease. So this is a significant health challenge that we might be able to affect with improved periodontal health. Periodontal disease and reproductive complications. This link is also considered an association, but there's a strong suggestion of causality with one particular bacterium, Fusobacterium nucleatum. This one was proven to cause a full-term baby to be stillborn. The mother was in her 30s, very healthy with a normal pregnancy and prenatal care. She developed an upper respiratory infection in her 39th week and noticed a lack of fetal movement. Subsequently, birth was induced and the baby was stillborn. The autopsy revealed a massive infection with Fusobacterium nucleatum in the baby's stomach and lungs, and plaque samples from the mother tested positive for the same strain of oral bacteria found in the dead baby's stomach and lungs. The Fusobacterium nucleatum had translocated from mouth to uterus when the immune system was weakened by respiratory infection. Now, realize that we used to say pregnancy gingivitis was just a little bleeding and it was normal during pregnancy, and not to worry, it'll resolve when your hormones are back to normal after you've given birth and after you finish breastfeeding. But patients need to know bleeding gums during pregnancy could lead to preterm low-weight birth, preeclampsia, and even the death of the unborn child. Now we'll talk about the connection between periodontal disease and cancer, and this is another example of an association. P. gingivalis is detected in 61% of cases of esophageal cancer. So if you have recognized PG in your patient's salivary test, and they also have symptoms of acid reflux or chronic heartburn or other gastric conditions, you should refer them immediately to a gastroenterologist. Esophageal cancer is difficult to diagnose early. It usually progresses rapidly and has a high mortality rate. So you could truly save a life by recognizing a possible connection and referring that patient. PG also increases the risk of pancreatic cancer. FN is linked to colorectal cancer, and together they are both linked to oral squamous cell carcinoma. Interestingly, oral cancer risk is increased in patients who have greater than 1.5 millimeters of attachment loss, and with each millimeter of bone loss, there's an increase of equal to or greater than 5 times the risk of cancer. Now we'll switch gears quickly, and we're going to talk about clinical protocols and how to use the oral systemic link information in clinical practice. So all of the clinical protocols listed on this slide and more can be part of a wellness-centered practice. Today I've talked a little bit about bacterial testing, and I'll talk about one more tiny piece of this puzzle, which is the implementation of wound care protocols. And as this Connect conference continues, you'll learn more and more about other protocols that you can implement in your wellness practice. And when we talk about wound care, we need to recognize that there are 2 different types of wounds, acute wounds and chronic wounds. An acute wound healing happens when the injury is followed by an immune system response that results in complete resolution and healing. Chronic wounds fail to heal in a reasonable amount of time. A chronic wound has a polymicrobial etiology and prolonged host degeneration. That's periodontal disease. So, Dr. Randall Wolcott from Lubbock, Texas was the inspiration for me. He is a physician who's done amazing work on wound care. He's credited with saving more limbs from amputation than any other physician. He's found that chronic wounds are covered in biofilms, and biofilms have an armor that protects them, like we talked about, from antibiotics and from disinfectants. So that means treating those biofilm infections with antibiotics is only minimally effective unless it's done in conjunction with other regular repeated debridement. So chronic wounds require intensive treatment. Dr. Wolcott's protocol involves repeated debridement of the biofilm in dead tissue and then repeated application of topical antibiotic gel. He also uses hyperbaric oxygen therapy, and then he uses xylitol for its ability to keep the biofilm from adhering to the tissue, and uses either xylitol, lactoferrin, or arginine to prevent the bacteria from clumping together. And all of this is done repeatedly for as long as it takes to heal the wound completely, usually 3 to 12 months of intensive treatment. Now, this was the least cringeworthy image I could find to share the process of wound healing with you. It's a complex process, and it's divided into predictable phases. There's blood clotting, inflammation, tissue growth, and tissue remodeling. So the chronic wound of periodontal disease heals the same way. The challenge is that we can't visualize most of the process. So we have established that periodontal disease is a chronic wound, and it makes sense that the same wound care protocols that are effective against chronic diabetic wounds would be effective against periodontal disease as well. So we can interpret Dr. Wolcott's protocols for periodontal disease treatment. Repeated debridement is so important because the pockets will be repopulated quickly, so you must continually disrupt that biofilm. Then we perform repeated application of topical antimicrobials or antibiotics following the debridement. And then we can use xylitol, arginine, or other products for their anti-adhesion and anti-clumping properties. And all of this is done over the course of several weeks. This means that the entire mouth is treated every time you see the patient. This is repeated debridement, not of a quadrant, but of the entire mouth, each and every time. And what we can observe are decreases in pocket depth, elimination of bleeding and redness, improved tissue tone and texture. And if we could peel back those tissues, we would see intact cellular tissues as opposed to the raw ulcerated sulcus of a periodontal wound. Dentistry needs to go out and lead this wellness revolution. And we need to remember that the further out we go on the wellness limb and away from traditional dental practice, the more fully rooted we need to be in science to back up what we're doing. So I hope you feel you now have a good understanding of the basic science behind the oral systemic links, and that you will take this information back to your practice with you in a very practical way. And I just want to share with you one more story. I started today by telling you about my friend Steve, and that I wasn't able to change Steve's story. But I was able to change the story of another friend, Howard. Howard is the nicest guy you'll ever meet. He's generous. He cares for everyone in the community. He will bend over backwards to do anything he can to help anyone. Howard helps everyone but himself. He's very overweight. He's a closet smoker, but I'm his dental hygienist, so I know. He's an uncontrolled diabetic. He doesn't exercise. He's a workaholic. He has 2 businesses of his own. He has a lot of stress, and he works late into the night. He doesn't sleep well, has a history of sleep apnea that he doesn't treat. And in his health history update one day, he told me that he had had the exercise stress test, and the doctor said everything was fine. Well, knowing my history now with Steve, you know that set off some pretty big alarm bells for me. So I was very concerned. His breathing was labored. He didn't look healthy. And that day, his blood pressure was 185/110. And I said, that's it. I can't take care of you today, and I'm very worried about your health. And I think you need to see a different doctor. And I referred him to a functional medicine doctor. Now, we had talked about this before because his blood pressure, this was not the first time his blood pressure was high. This was not the first time that he didn't look good to me. But he always just negated everything that I said. And when he came in this day saying, hey, I had that stress test and I passed just fine, it really changed something in me. And I said, that's it. I'm going to be so serious with Howard that it makes a difference. I need to move the needle here for him, or we're going to lose this really valuable member of our community. So I got serious with him, and I know he felt it. And finally, something clicked for him, and he took that recommendation, and he went to see this functional medicine doctor. They did a CIMT test. They found plaque in his endothelial arteries that showed that he was 25 years older than his chronological age. And of course, his blood sugar was not well controlled and everything else. So this doctor recommended multiple lifestyle changes. They talked about his diet and exercise and stress reduction, and Howard took it seriously. He changed his eating. He got a dog. He walks that dog twice a day, which is great exercise and reduces his stress. And he finally let me treat his periodontal disease, which I'd been trying to do for many years. So I used wound care therapy protocols for Howard, and we treated his mouth multiple times. And now, let's see if I can show you Howard today. He is now very thankful for this wake-up call. He had the opportunity to make positive changes, and he tells me that I saved his life by recommending that wellness-focused doctor and by treating his periodontal disease. And when I tell you that we have an incredible opportunity, we literally can save lives and families. And Howard is more than just my patient, more than just my friend. He's my brother. And this is what I want for you. Happy ending stories just like this. And before I go today, I wanted to offer, at this time of unprecedented uncertainty, I want to offer this complimentary opportunity assessment to any dentist who'd like to discuss ways to get back to work with a bang once we can see patients again. If you're interested in discussing some ideas for your team, feel free to schedule a call with me on my Calendly. I would love to hear from you, and I'd love to help you any way that I can. Thank you so much.
Thank you so much, Kathryn. This is such important content. We have a lot of questions coming in, so we'd like to take a couple of minutes to answer some of those. So we have a few people that are wondering if insurance will pay for the salivary testing, and if so, what code to use.
I believe there are some insurances that will pay for salivary testing. And if I remember properly, there are two codes. There's a code for collection of the sample and code for the actual lab work assessment, which I believe are D0417 and 0418. And I believe my friend Jennifer Sider of Microblinks DX is on the call, and she may be able to clarify that and just double check what I said. I believe it's 417 and 418.
Okay, perfect. Are you doing bacterial pathogen testing for every patient?
If this Kathryn's perfect ideal world, yes, but in reality, it's not. So no, I want to do this for every patient, but in reality, I get to do it for almost every periodontal patient, but not even every periodontal patient, because this is often an out-of-pocket test for those patients. So there are some people who refuse this test, and there are some people who put it off, and we don't do it initially, but if we don't get the results that we're hoping for, then they will agree to the test later, and then we can do it later and see if we haven't had great results without antimicrobials, then we look to see which pathogens are present, and we may do either topical or systemic antibiotics later.
Okay. And which pathogen tests do you use and recommend?
I personally use two tests. I use the Microblink DX test and the oral DNA test. To me, of all the tests that I have tried, and I believe there are 4 on the market, but don't quote me on that. There may be more now. I think at the last meeting I attended, there were actually more coming on the market. And soon there will even be a chair-side test that we can do. But the two that I use and really like are oral DNA and Microblinks DX.
Okay. If you could
and let me just say,
oh, sorry.
I'm sorry, Lacey, let me just interject. The reason I really like those tests, they're easy to perform, and the results are easy and very clear to read and very easy to explain to the patients, and then you can send the report home with the patient. But they do make it easy for us. Not everybody has to be a microbiology nerd like me. I just wanted to share that. Don't be afraid.
Okay, thank you. So if you could only use a microscope or a pathogen test, which would you recommend?
Well, actually, I used to use a microscope, and I'm in that situation myself now where I don't have a microscope. I love the microscope for allowing the patients to see that active slide and to see all the bacteria in their mouth. It's very motivating for patients. But if I could only do one, I would do the pathogen testing because it gives me much more detailed information about the specific bacteria that are present, and then I can connect the specific bacteria for that patient, for their individual risk factors. So for me, the bacterial test is number one.
Okay.
If I could do both, I would.
Would you say that you have a wellness practice if you're testing for pathogens and doing repeated debridement?
No, I would say that you're on the way to having a wellness practice, and I think that's a great thing. But a wellness practice really focuses on even more than just doing repeated debridement for your patient, which I think is huge, huge, huge. And it's even more than doing bacterial testing. It's looking at all aspects of the patient's health and all of the various ways we can help them. We would be looking at doing HbA1c testing, doing smoking cessation programs, doing all sorts of things, maybe a cardiovascular screening test in the office, the CIMT. There are so many things that we can do, and if you will watch this Connect program every single day for the next, I think, 28 more days, you will hear from Dr. Doug Thompson, who's actually tomorrow. You'll hear from Dr. Susan Naples. You'll hear from multiple different experts who have wellness practices of the multiple different protocols that they have implemented. And you'll see that this is a great time to transition your practice and to transform from a traditional practice to a wellness practice. But it is more than just what I touched on in this 1 hour.
Thank you so much, Kathryn. Dr. Cooch, do you have any questions or anything that you would like to add before we head into the wrap-up?
Oh, I just want to say thank you, Kathryn. That was a delightful hour. I was sitting here, thank you so much for your passion and being such a champion and sharing this valuable information that's so needed by our profession. I think it's such a great time for us in dentistry to, I think, extend our ability to help people, as primary care providers. I mean, when you talk about, a wellness practice, looking at airway issues, sleep apnea, GERD, diabetes, you can go down the list of all the things that we can actually help identify and help the patients with. I was just sitting here reflecting back. I first started talking about periodontal disease and inflammation and risk for heart attacks back in '99 when the first studies were published on C-reactive protein. And it really raised an alarm for me, and I thought, you consistently started to see these studies, and I just remember all the pushback I got from so many of my colleagues that were, literally, oh, that's just a coincidence. And I'm like, how can you read this scientific literature and not come to this conclusion? And it's so refreshing, although it took so long, with champions like you and Amy and Brad and Doug and Susan and so many people in the profession that have been out teaching this for so many years, that now we can have these kind of conversations where, yeah, we all just accept it. This is like, yeah, we get it, we understand it, we're doing it. In fact, if you're not doing it, it's a problem, right? And so it just feels really good to me, and thanks to you for making all of that happen, Kathryn. Thank you for being here today.
Thank you. It is my pleasure, and I have to say that I followed you and some of these other experts for years. I was searching for you. I knew that there was a connection, and it means so much to me now to be a part of this community, to be a part of AOSH and all of the organizations that recognize these connections. And, at first when I started talking to, people were talking to me about, when I talk about screening for airway issues or whatever we're looking at, if it's glucose problems, that was out of our scope of practice. And people were really clamoring that, we didn't know what we were talking about, or we were encroaching into medicine and we had no place there. But like you said, it's finally accepted, and it's so refreshing to have other people coming on board and understanding these connections and wanting to know more about it, wanting to expand their practices and really helping people. And I think now, in the midst of this global pandemic, it's such a blessing that you're offering all of this free continuing education to our peers. And what that will do is bring more and more people into this arena with us and into this point of view with us that we are really responsible for the whole health of our patients and that we need to co-manage them with their physicians and be partners with them in their ultimate, quest for better health. And it's really exciting to be here, and it's a huge honor for me.
Thank you so much, Kathryn. We love having you. Okay, so before we let everyone go, we have just a few items to mention. If you have questions that didn't get answered today, Kathryn has included her direct contact info on the screen, so you're welcome to reach out to her for more information. If you haven't already joined our Facebook group, please consider doing so. After the session has ended, you'll be directed to the link where you can join, and this is a great opportunity to continue networking with your peers and speakers. We will also be posting the recordings into the group daily, as well as some additional bonus content. But if you're one of the rebellious that doesn't have Facebook, don't worry, we've got you covered. We'll be sending the week's recording via email on Fridays. Feel free to share these recordings with colleagues, friends, and family members. Again, the quizzes and evaluation forms will be sent by email at the end of the week. Once you complete them, your certificate will be issued within 60 days. Here's a quick glance at the rest of the week's sessions. On Wednesday, we have dentist Dr. Doug Thompson discussing wellness dentistry in the midst of a health revolution. On Thursday, hygienist Kendra Sellers talking about why medical billing is more important than ever. And then wrapping up the week on Friday with Dr. Julie Kellogg and Dr. Karen Tyndall discussing coaching for generations in crisis. Last but not least, our team at Carefree wants to extend a giant thank you for joining us on these sessions. We hope this hour each day gives you some time to plug into something productive and positive, and we really appreciate your support. We wouldn't be able to do this without you. Dr. Cooch, I'll let you say the final words.
Well, thank you, Lacey, and thank you, Lacey, for hosting this. I know how much work goes on the back end of putting these programs together, and you and the team have done a fantastic job. I just want to, just tell everybody, be safe. I know these are unprecedented, I think, challenging times for all of us on a business, emotional, personal, family level as well, and I really appreciate you guys spending an hour with us every day. I'm really enjoying this myself personally, just to have an hour every day that I can think dentistry and get my mind off of all the rest of the things that are going on in the world. So it's our pleasure to be able to sponsor and help with this, and I appreciate all of you. So everybody just be safe, and we'll see you tomorrow.
All right, thank you. See everyone tomorrow.
Bye-bye, Kathryn.
Bye. Thank you so much.